disparities in access to health care. And, you know, in our work in terms of focusing on children and families and adults who have behavioral health needs, we understand the impact of social determinants on our work and outcomes for people who live in marginalized communities in particular. And so that's why we're doing this event today. So many communities, we know, face significant barriers to quality health care due to factors such as, you know, not having viable healthcare providers within proximity. Some of it has to do with structural barriers around racism. And we know that there are policy gaps. So today, we're excited for the conversation that our panelists is going to have as we really focus on trying to educate people around how to empower themselves and how to advocate for others. And so I would be remiss if I didn't take this opportunity before we start this program today to really acknowledge my staff from Child Guidance Resource Centers. And so if my staff could stand at this time, Luana and Jerry and Raja and Maisha and everybody, come on, the rest of the staff, stand up, Katie, everybody. Inspire hope and to remove barriers from people struggling to really just normalize and have a good quality of life is incredible. And so if I haven't said it this week, I want to go on record of saying it this year. Thank you. Thank you to all of the Child Guidance Resource Center staff members for everything that you do to really inspire hope. And then I would be really remiss if I didn't acknowledge my board members. If my board members could please just stand and let's give them a round of applause because what they do, they don't get paid to do. They show up and they provide us with support. And as I enter into my 6th month as the CEO and President of Child Guidance Resource Centers, I remain optimistic about the future of our organization as I continue to foster relationships and build trust. And really focus on the transition that we're going into as we launch our strategic planning process. It is an exciting time. It is an exciting time. And so, at this time, it's my pleasure to introduce our board member, our Dr. Simmons, our Willie. We call her Willie, affectionately known as Willie. And she's going to be your moderator for today's program. And again, we just want to thank her for always taking her time and using her expertise and her voice and her charisma to join us in these very important conversations that we continue to have in our community. So Dr. Simmons, please, let's give her a round of applause.
All right. Good afternoon, everyone.
Good afternoon.
You're looking good. The cold has nothing on you. It's nice to see you all. All right. So this is a very, very, very exciting day, and thank you to our panelists for taking your time to be here. Thank you to everyone for taking their time to be here as well. As Dr. Kate mentioned, my name is Dr. Williametta Simmons, known as Willie. I'm a psychologist, a humanitarian. I told them I'm going to meet this morning. Psychologist, humanitarian, and board member of Child Guidance Resource Centers. Today's event is hosted by a joint effort between Child Guidance Resource Centers, our Diversity, Inclusion, and Equity Committee, as well as our council, our Government Relations Council. Okay? Child Guidance delivers evidence-informed behavioral health services and community-wide wellness programs to children and families through the 5-county Philadelphia region. Healthcare access should be for everyone. And without access, disparities in health outcomes deepen, perpetuating cycles of poverty and limiting opportunities for individuals to thrive. Today, we bring you panelists who will share their views on the together for a solution, or for solutions rather. Our first panel today includes individuals from local organizations who work in various capacities to improve the well-being of our communities. I would like to go down the line to all of our panelists. Please briefly introduce yourself and or the organization that you're representing. There you go. Take your time.
Good afternoon, everyone. My name is Dr. Kimberly Arnold, and I am here from the University of Pennsylvania, Perelman School of Medicine. I'm an assistant professor in the Department of Family Medicine and Community Health within the Community Health Division. I'm really happy to be here and looking forward to talking with you all about this very important topic of health disparities. And all of my background and training is in public health, so I have a lot to share, but I definitely would love for this to be more of a discussion, not just between the panelists, but also with you all as well. So looking forward to it. Thank you. Oh, and one last thing. Most of my work is focused on improving the implementation and sustainability of evidence-based mental health interventions in community settings, mostly churches and schools. And with that, I'll pass it on.
Hi, everyone. Oh, sorry. Felt like, I don't know. I'm better at yelling, so the microphone is stressful. My name's Sarah Messina. I am a licensed marriage and family therapist. I'm the director of Montgomery County Prevention. In my capacity in that role, we focus a lot on evidence-based practices and working with families and children, and really focusing on parent education and helping to boost protective factors to help better outcomes for kiddos and families. I think that's pretty much it.
Hi, I'm Tony Salvatore. I'm with Montgomery County Emergency Services. We do the crisis mental health services for Montgomery County, everything from a hotline to inpatient care. And we also are the call center for Montgomery, Delaware County, and a few other counties. And one of the things we do for the community is for the last 25 years, we've run a fairly substantial suicide prevention program. Focuses mostly on adults and older adults where unfortunately most of the dying actually occurs, but we have supported schools and other activities. In terms of my comments today, I'm pretty much going to speak from my experience in adult mental health and our recent the activity that we've received on 988, distress calls, emotionally concerned people, especially with potential policy developments affecting their services and livelihoods. I appreciate the opportunity to be here today. Thank you.
Now, this morning I woke up and my left ear is kind of cloggy, so I don't know if it's me or if our sound is okay. So can you hear our panelists?
Yes.
Okay. And am I talking too loud?
No.
Okay.
I feel like the first microphone was better than the second.
Yeah. So we should just pass the first microphone and then we'll turn that one off. The second mic off. Thank you so much for your feedback. And if I'm screaming, just give me a little light. So I know. Okay, thank you so much. So for the at this point, we will transition into asking our panelists questions concerning our current topic, which has to do with health equity. All right. So you can take your turn and answer. There's no first place, second, third place, third place. Whoever wants to answer first, then feel free to do so. So let's get into it. What are the most common factors, including social and economic circumstances, that's contributing to disparities in access to health care?
I guess I can start. So this is a loaded question, of course, and I'm sure many of you have firsthand experience, whether from your own experience or from working with people who have challenges as it relates to socioeconomic status or accessing healthcare. But if we start with socioeconomic status, we know that people who have lower levels of income face greater challenges as it relates to affording healthcare, paying for insurance, or even covering some of the out-of-pocket costs. And then as far as geographic location, most people are probably living in either urban or suburban areas, but we know that rural communities often lack hospitals, specialty providers, and mental health services. And although urban or suburban areas may have a higher number of hospitals or specialty providers, or even a higher number of mental health services, most people may not even know where to actually access those services if they're really struggling. And so some of the work that I've been doing in and with communities, people come to us, especially through churches, trying to seek help. And many of them live in the city of Philadelphia, where there seems to be a ton of services, but sometimes they don't know necessarily where they can go to services to receive care from people that they trust. And then also with educational attainment, lower health literacy can hinder understanding of medical advice or the ability to navigate healthcare systems. And so even when it comes to scheduling appointments or trying to navigate the websites of different healthcare providers, that can be difficult, or even trying to understand all of that paperwork people get with their prescriptions and trying to read through that and really figure out what are the side effects and when they should take their medicines and things like that. And then for employment and insurance coverage, people who are working low-wage or part-time jobs may lack employer-provided health insurance, which can cause issues. And for housing insecurity, people who are experiencing homelessness or unsafe housing conditions are less likely to access preventive care, which we know is extremely important. And then last, historical and structural barriers are also a contributing factor and sometimes underpin some of those social and economic circumstances. So things like racism, discrimination, redlining, and exclusion from economic opportunities contribute to long-standing disparities. And I'm sure we'll get more into that later, so I'll pass it along. Yeah.
I mentioned a couple of things. Several years ago, we had an opportunity to do something a service like us doesn't get much chance to do. We're largely facility-based. Our main service is a hospital, a crisis center, a call center. People call us, come to us, brought to us. But briefly, we had a grant that allowed us to have our nurses follow patients home. And it was an eye-opener. Because, I mean, among these nurses, their community health experience was limited to their practicum when they were, in BSN programs, something like that. But what they saw when they basically started seeing patients at home is some of the social determinants of health at work. One of the big ones was who was sitting on the front steps of the apartment. Why wasn't somebody getting out to keep their outpatient appointments? Why were they unable to keep their meds? We supplied them, sent them home with meds, but they had ongoing prescriptions. There was no transportation. The closest pharmacy may have been beyond walking distance, and then may have been beyond them. Things like that. And unfortunately, we had hoped our managed care payer would have not so much kept us in the loop of this program, but maybe kept it up. Because most of the other home care services aren't particularly mental health, let alone psychiatrically oriented. But we saw that. The other thing I want to touch on in terms of our patients is the income insecurity is probably and housing instability are probably the two biggest factors. Even people that have coverage are still spending money on other things like food or paying for a room by the week or something like that, and then if they're hospitalized, losing that room. So housing has always shown up as a factor in readmissions to inpatient psychiatric care, at least at our facility. So that's something I think
Yeah, I think even in our work, working with parents and families, we often have families reach out that are being evicted from their homes, losing childcare because they're starting to make too much money, and now childcare is becoming a huge stressor on them. So I think in general, we have a lot of families in our work that are kind of towing that line between making just a little bit too much money to qualify for anything, or not making enough money, and they might qualify for health insurance through through Medicaid and things like that, but there's also no providers once they're there. There's wait lists a mile long, so even if they are able to qualify for those health insurance benefits, there's no providers or qualified providers for what they need available to them. But we really, I think even for us here in Montgomery County, we see families across all of the communities that are constantly kind of trying to navigate that system of being able to make enough money to sustain, but also not too much money, because then they lose everything that is their access to care.
I am in multiple positions. One, I am the new pastor at Macedonian Ministries, which has been in the community for almost 100 years. And I also work for CYF in Chester County. So I work both in children, youth, and family services. I've been a long-time social worker, 20-something years, and I'm also pastoring in our community here at Macedonia.
Thank you so much. And if you'd like to tackle the first question, or if you'd like to decompress, that's fine. But I'll pose this question that was just answered, and if you'd like to give any feedback to it, that's wonderful. The question was, what are the most common factors, including social and economic circumstances, contributing to disparities in access to health care? The most common factors that contribute.
Might have been mentioned already, but in the area in which I deal with, you see that there's definitely a divide with those who are in that level of without having a job, economical issues, poverty. Certainly there is a divide in the access that they have comparing to others who have the economical ability to take care of those types of things. You see that extremely in Chester County in the divides of certain areas in Coatesville and Honeybrook, but then in other areas there's a difference in Malvern and Tredyffrin in the economical divide. So there is certainly that issue that I think is an issue that we have to, not only in healthcare, but also in affordable housing, which also affects the healthcare too, which I'll get into later. Thank you.
The next question is, how does systemic racism, including cultural and language barriers, contribute to disparities in healthcare access and outcomes?
Okay. Yeah. So with many of the factors that we just talked about in terms of inequities and social determinants of health, systemic racism is directly linked to that. So some of the effects of that yields implicit bias in care delivery. So we know that there are many studies that show that Black and brown patients often receive lower quality care, including delayed diagnoses or insufficient pain management, and then just also sometimes just difficulty with trusting providers, especially providers that may not look like them. And there may have also been situations where patients have had negative experiences with providers who may have treated them differently because of how they look or what their background is. And we've also had situations where some patients, even though they may be in pain, do not want to go to the hospital just for fear of what may happen to them due to either past experiences or people that they may know who were not treated well by the healthcare system. And then there are also situations where there are cultural misunderstandings, and some healthcare providers may fail to even consider or respect culturally specific practices and beliefs. And then in addition to that, there are language barriers, and so patients with limited English proficiency face challenges in discussing their symptoms, understanding treatment options, or following the medical instructions. And then, of course, when we look at the history of the healthcare system within the United States, there are several instances of historical, medical, and public health research abuses. So I'm sure most people are familiar with the Tuskegee syphilis study. So that's a prominent example, as well as the situation with Henrietta Lacks in Baltimore. And so, in addition to some of those like really big stories, people also, again, have had their own personal experiences and know of people either in their family or their community who have experienced mistreatment by health providers, and has created some general mistrust. And it also leads some communities to completely avoid seeking care altogether, which can also limit their ability to get the care that they need. And then there are also, at the policy level, there are exclusions that may not account for certain groups, such as undocumented immigrants who may need care but aren't able to access that care. So when we take all of these different things together, we can kind of see that common thread there is systemic racism, and the effects have kind of trickled down into some of the things that people may experience on an individual basis as well.
You good? I feel like she just like mic dropped on that question. So she came ready. So I don't know that I have. I don't know if I actually have anything to add to it. That was really well done. I'm gonna, unless anyone else does. Go ahead, we got.
Speaking from a mental health perspective, I think the problem with culture, language, is that the field itself is basically biased in a certain direction. I mean, it's much easier to access, navigate, if you're at least middle class, and English is your primary language and things like that. The other problem is it's largely diagnosis oriented. So things that happen to you in the mental health system, irrespective of who you are largely dictated by that initial psychiatric evaluation that basically puts a diagnosis on you. So your treatment plan, whether it's outpatient, inpatient, your discharge plan, who you refer to, things like that. And I think less so, well, I worked in community health some years ago, but I'm not up on what practices are in the medical healthcare system so much today. But I think they've kept up a little more with it. We also have seen things like not understanding the relationships people have. Like, for instance, when one person in the household, like I remember a family we had, I think they were Hmong, everybody, wanted to be in the evaluation, not just, the patient. And it took some understanding to basically separate them out. The perception of medications. Some of the folks we'd seen, for instance, in the Latino community, had experience with medical illness, and they realized, you can basically stop an antibiotic, but you can't quite abruptly stop some antipsychotics. And it was, again, things like that I think you don't typically learn in graduate school. Very often. I'm not sure about medical school, but I think it's things that make the services more cohesive in terms of the community themselves. Last thing I'll say is, some years ago we had a board member, a lot of board members here today. We had a board member who was very active in the Norristown community, and he used to ask me to come once a year. I don't know if it's Mental Health Month, whether it was May or October, and talk about mental health. And when I would be there, I mean, the community was basically folks from Norristown, meaning it was largely people from the African-American community. And when I would talk about mental health, I would get feedback like, "That's not our problem. We don't see depression. You know, what are you talking about?" Now, I don't know how much that's changed, but you know, I would say, well, I wouldn't argue with them because obviously I wasn't part of that community. I wouldn't know where their values were coming from. But I said, unfortunately, we do see patients that didn't get care at an early stage of an illness, and then unfortunately had to be brought to care sometimes, often at times involuntarily. So again, it's another kind of perspective on access and how culture affects it.
Sorry, now. I was going to say, I also think, given the current state of our world, we are living in a world where people are actually afraid. They're afraid even to apply for benefits. They're afraid to walk in and let someone know that they're undocumented. They might be themselves okay, but they have family members who aren't, and they're afraid. So I'm not sure. I think it's important to note, and it's alive and well happening every day right now. Language is also... Every time we turn around, it is so hard. Language barriers are everywhere. We don't have enough clinicians in the mental health field to speak Spanish, let alone the gamut of other languages that we need. So just access, the ability for people to find someone who looks like them, and then also find someone who can actually effectively communicate with them is next to impossible for a lot of people. But I think it is worth noting that the way that things are going right now, we have people who are literally, they won't even send their kids to school, let alone go to the doctor, because they're afraid of what will happen to them. And it's horrifying.
If I could just add just one thing. I'm an old guy, and so one of the many things in our communities, coming from Philadelphia, we didn't necessarily trust the medical society, especially when it came to our mental health. And many times, I always use the expression, many of us had dysfunctioning things that were happening in our families. There was always a weird Uncle Harold somewhere. And in that process, our way of treating Uncle Harold was, don't go over Uncle Harold's house without your mother or father. We were very careful about that, but we didn't necessarily go and get therapy for Uncle Harold. We didn't go and get therapy for ourselves because we didn't trust therapy. We didn't trust folk to be able to examine our minds, especially as African American men. That was not something we would do because that was a sign of our time weakness. Times have changed. I think we have a different thought process about therapy, about doing those kinds of things that exist in communities at time. Again, from poverty, from access, is that in mental health, the more difficult, more to go to find the right therapist or that therapy that you want, and so the access there is much more difficult than even getting the physical health. But mental health, finding the right doctor and finding that doctor that will take your insurance is much more complicated.
So be mindful of time. I see Dr. B. Did you want to say anything?
Yeah, I just wanted the pastor to maybe talk a little bit about some of the cultural variances. There is an intersection of faith beliefs in terms of African Americans sometimes believe in terms of religious practices, spirits, and the intersection of science and faith. And it's been a huge issue in our community with people thinking that if they're a particular cultural value around religion, that how that intersects with accessing care, because there's a belief that, we can pray those spirits out of the person, we can just take them to church, and so those cultural pieces certainly have huge implications for accessing care, and even with people not getting therapists who may not culturally understand some of their values, and the intersection and the tension and the intersection of your treatment plan and people not understanding your values. So I wanted to hear if the pastor had any thing to add, or if anybody had anything to add about racism and cultural variances in terms of accessing mental health care.
And certainly in the African American church, there was again that distrust, and that rather than going to the doctor, let the pastor lay hands, and those kinds of things, and trust God. And I believe they are still there in the sense we trust the Lord, but I've taken on, because of my background, I've always believed every good pastor needs a therapist. That's one thing, including myself. And there are certain things from a therapeutic standpoint when it comes to the mind that needs to go to therapy. And so I think it is changing, transitioning with younger pastors and folk who've come out of that experience, that certainly we believe God can do all things, but that also means that we also can get the medical help. You know, it's transitioning, because we see more of our folk who are diabetic, more especially African American who are having prostate cancer. And so our church and other churches are doing health conferences, which you didn't see maybe 20 years ago. We're doing mental health conferences and really telling our people, please, get the medical assistance that you need moving forward. So I think it's transitioning. There are still those that are holding on to the distrust culturally and saying, I'm just going to trust the Lord. But I said, you can trust the Lord to help you find the right doctor. You can trust the Lord to help you find the right therapist. I didn't mean to preach, but y'all just told me.
That's a great point. Thank you so much. I know that I'll start getting the look soon because it is 2 o'clock. I'll share this really quickly. There, in terms of, because the question had to do with cultural and language barrier. And so prior to coming here, I was doing some consulting for the African Cultural Alliance of North America. And prior to coming here right now, this morning. And one of a perfect example of language barrier has to do with the fact that, you talked earlier about assessment and diagnosis, and there was someone who was diabetic, but when they went to their primary care doctor, the person said, oh, do you have diabetes? Do you have this and that? And they said no. And then when they came to us, they're describing, they said, yeah, I suffer with, I struggle with sugar. And the physician didn't say sugar. They don't know it as diabetes. So she said, I don't have diabetes, right? And so sometimes it's simple things like that. It's cultural things. Another thing from like the African and I would say islanders perspective, we don't always have language for emotional experiences. It's more manifested through physical. Like they'll say, oh, my head is hurting, or my heart hurt, or my back, or my, and it's really essentially addressing maybe it's anxiety, or maybe it's a level of depression, but it's not always going to be spoken in the words that we're used to hearing. And that's why it's important to have cultural conceptualizations and culturally sound individuals when you're working with different people. But those are just some examples. And with regards to the religious piece, some maybe to you, know that I'm a minister outside of all of this. And one of the things that I always tell people is that the Apostle Luke was in fact a physician. And so if we see that there are, even in the days of Jesus, we had physicians, So if there's absolutely nothing wrong with praying and with saying I'm going to go to the pastor, but certainly we are God's hands and feet. And so he places individuals in our lives to be able to help us, bring us to healing. So we don't just have one option, we have multiple options. And so there's a smooth intersectionality between our faith, between our beliefs, and still being able to integrate science into the work that we do. So just summarizing.
I'll just hit it from a suicide prevention point of view. Essentially, all of the risk factors for suicide are basically related to things like loneliness, poor social relationships, lack of support, and it gets worse as you get older. I mean, for instance, it's not given much attention, but the population in the community that has the highest risk of suicide, I'm the poster boy for. Old white guys. Now, not just to mean there's a lot of deaths, but there's a high rate of deaths. And that brings me to a different angle on this. I think I'm even older than the pastor, so I might remember some things he doesn't. One of them was, in the 50s, I don't remember any of my mother's friends having heart disease. I never heard the word cardiologist. However, in my dotage, am I right, doctor, that is one of the leading causes of death among women in the United States? Now, how did that happen? I mean, obviously, there was some evening out of risk factors, but we don't pay attention to risk factors. We pay attention to incidence and rates and things like that. So if I jump to a more related term, in the black community, there's a high incidence, not so much in Norristown or Montgomery County, but nationally, increasing incidence of suicide in preteen black children. So much so that the Congressional Black Caucus actually issued a report on it. It's online. You don't have to take my word for it. You can read it. What I'm getting at is, okay, we're looking at prevention directed at that. But what people are missing the boat on is the kids who don't die, who are acutely suicidal, carry that risk with them. So one of these days, I may not be around to see it, somebody's going to note, oh, there's a high incidence of suicide among elderly black men. Where did that come from? Well, it's from the risk that they incurred as 11-year-olds, 12-year-olds, or whatever. Now, of course, part of the problem is discerning the actual issue. One of the highest causes of death in young people, black or white, is accidents. Well, how do you tell an accidental death from an intentional death? You can with adults. Adults leave notes, adults talk, adults use firearms. Some children do too, but they don't. So I'm getting at, I think, looking at protective factors, buffers, earlier on, as opposed to just rates, and looking at how they're influenced by culture and language and resources is something we shouldn't miss the boat on.
Yeah, I mean, and to kind of stick with that risk factor and protective factor piece, one of the things that we know in families and children is that a strong connection to your family, good relationships with your parents, an ability to communicate effectively within a family, parents with clear expectations and understanding and ability to have conversations with their children are positive preventative factors for children. They help address things like mental health. They help address things like suicide risk. And when you're living in housing instability and when you can't figure out where your next meal is coming from, it's really hard to sit down and have a family meeting with your children and communicate with them and have conversations. So our kids are missing out on a huge risk, or on a huge protective factor, by the simple fact that their parents are not actually, they don't have the opportunity to build that connection and build those strong relationships with them because they're just trying to make ends meet.
In our world of children, youth, and family services, we see that there are many families, black, white, across the board, who are struggling to find affordable housing. And when I call it, there's a lot of folk who may not be homeless, but they're living in unstable housing. And what I mean by that, they're going from pillow to pillow. They're living with auntie from 1 week, maybe grandmom another week, and they're taking their 4-year-old child or 5-year-old child with them, going from place to place. They're going from one school district to another, and in some cases they're not even going to school at all. And when you do that, and when you're living in that kind of unstable housing, what people don't realize is the traumatic effect that it has on a child, because I don't know where I'm going to be staying at tomorrow. I don't know where my next meal is going to be. I have a nephew who we primarily have adopted and is living with us, and I'm raising a 17-year-old as an old guy. But he had to recognize there was going to be food always in the refrigerator, because from his past, he never knew when there was going to be food. Just imagine the mental stability and the traumatic experiences and the anger he was experiencing on being almost in that situation of homelessness, and then growing up with it, and now being 17 and still dealing with that issue. And so it is real. It is something that we have to deal with. I'm an individual both in Montgomery County and Chester County. We have to come to this reality. We need affordable housing for people. We need affordable housing. And I know a lot of communities, especially rich communities, they don't want to hear that. But at the same time, they don't want the tent communities in their areas either. So we need to figure out a way of how we can house people to get them into stable housing.